Video, audio.
So,
Yeah.
am I audible now?
Yeah, yeah.
Yes?
Okay.
Okay,
Yeah,
I'm
yeah.
sorry. So I just wanted to first compliment Dalal sir, because whenever we hear him, it is philosophy and learning and science, not only for our children with diabetes, but also for our own selves. So it's always inspiring to go the path that sir sets, and I try never to miss his talks. And I incorporate and steal a little bit every time to incorporate it into Udan's work. The
Real world
introduction,
story. Real world story.
True.
Real world story.
Real world, actually. So today I'm going to speak very much as an extension to what communities and families in type 1 diabetes management. So I will try to make it more, sorry, I think the internet. Am I audible?
Yeah, yeah.
Yes. Okay. So there's no
Yes,
conflict of interest. All the pictures that are here are of children from Udan. They have been taken with permission. As you mentioned, that Udan today is now 900 families. That slide of introduction was 10 years old. So now it's 20 years of work with 900 families. Whatever we have learned is also from science and from experience of actual work on the ground with children. And the goal which we have also set with the RSSDI task force, because when we are empowering them, our goal, as Dr. Dalal sir mentioned, is not merely the blood sugar levels. So type 1 is a different game altogether, a different field altogether, because the goal is also a physically but also psychosocially healthy citizen of India with type 1 diabetes. And when we look at this, then empowerment has a different meaning altogether. And hence the challenge, hence the need for so many workshops, hence the need for so many new policies, etc. What we also have to understand that when we start working, that there is a disparity. India has many Indias within it. So we do have people who can afford the insulin, can do complete artificial pancreas, which is great. And as Sir said, that would be a dream when we could do our own research and have it affordable for everyone. And that dream has to be seen. Only then it will be possible. But at the same time, as we have children who cannot afford even a meal a day, and yet we cannot afford to lose them. So the dream and the policy and the plans that we make have to cater to everyone, and we have to be equipped from all angles, and that is very important. So if we do a reality check, definitely wherever everything is affordable, that is probably a best case scenario. Maybe we can have an insulin pump or at least analog insulins and CGMs for all those who can. But having basal bolus insulin, having a glucometer with adequate strips, having nutritious meal on the table, that is approximately minimum 3,000 rupees a month for a child. We are not even talking about hospital expenses or the consulting of a doctor. And most states, these are not available in government hospitals. A lot of talk has been happening. We have been requesting for at least a minimum cost, because the cost price on average strip would be only 2 rupees, at least if we had subsidized strips or something to that effect. That is a big issue. So when we are empowering them, the medical need, if it's not fulfilled, it is very difficult to encourage a person from a psychosocial, emotional angle, because first they want food on the table and adequate medicine to keep the healthy and alive. So that is something we have to work on when we are talking about empowerment. Again, accessibility, even if there is money. I work in Marathwada, and there are so many villages, even if they have enough money or they're willing to source it from somewhere, but there is no doctor. They don't have access to a healthcare provider who knows what type 1 care is. So these healthcare providers not being aware or accessible is something which is a very important path we have to see. But wherever they are available, for example, in a metro city, how many pediatric endocrinologists or centers that have a structured program for diabetes care? So at least there we have to see to it that they go and reach out to them. I know people who are in Mumbai and yet are saying that we don't know where to go. So we really don't know how do we reach to them and tell them these are the 10 places in Mumbai where you can reach out to a structured program. Because how will they empower themselves, their family, their school, their community if they don't know where to go? So I think we still have a lot to talk about, a lot of advocacy, a lot of shouting at the rooftops till people know about it and can reach to everyone. And of course, there is a socio-cultural barrier which may come with lack of education. But let me really say this out of experience, it is not really about socioeconomic strata. So all kinds of thoughts and myths and hang-ups are there. I have the richest of patients who are depressed, who have not accepted their diabetes, and the poorest of patients who are doing so well, they have accepted their diabetes and moving on in their life, doing great things. So it's not about education, it's not about money when it comes to acceptance. It's very individual. And as Sir mentioned in his presentation, there's a whole path which could be spiritual, which would be a journey inwards, and somebody can help. But we have to look at affordability, accessibility, and acceptability before we actually think of how to empower. So it has to be a reality check. Where does this person fall? And then we go ahead. So our mission is to provide a positive T1D ecosystem. And that mission first is procure and provide insulin. There's always a saying on when you don't have the basics, it's very difficult to go forward. So one is that, and second is to provide monitoring, whether it is glucometers and strips or it is CGMS or whatever. We dream big, but we go step at a time, and we have to have these basics. And the third would be the nutritional guidance and carbohydrate counting. So it's not just nutritional guidance. People feel that carbohydrate counting is something very exotic and can't be done, but every person can do it. We have to know how to teach it. That is more important. It is the onus is on us. And that will go a long way, because I see people who may be on a basal bolus therapy, but they're not able to judge their food and they are not able to adjust their dose. As a result, being on a best of insulin therapy, the outcomes are still poor. So this is something we have to focus upon as doctors, as an educator team, as type 1 care providers. And the crux is always education, education, and education. So ultimate empowerment is going to come with education, and how we educate is our biggest challenge, and then motivate and empower. So I just put it in this series because unless and until we have insulin, glucometer strips, some knowledge about nutrition and education, only motivation is not going to work. I mean, I can say all the nicest things to my children and their families. What will motivate them unless and until the basics are in place? So first, feed the empty stomach and then think about something next level is what I would say. And how do we do that? So we have problems in the healthcare system, the social context, and we have poor outcomes if we do not have that. So all these challenges we are aware of. I will not go into them. But when we look at these challenges, we have to think of what can we do about them. And I have just today, for today's talk, divided into various parts, because when we are empowering, I feel the first empowerment has to be of us, the healthcare providers, our doctors, because I work in rural villages and I feel the doctors are not able to detect or be able to find out, diagnose type 1 diabetes. 95% of my kids have come in DKA. So they could not. In fact, my type 1 parents who had a second offspring with type 1 diabetes could detect very early, but the doctor could not. So again, all these programs, such as the RSSDI program that is being rolled out, I think this is very significant in reaching out to every doctor, including GPs, school teachers, ASHA workers, as Sir said, all of these people. So the problem is illiteracy, social myths, lack of dialogue, GPs unaware. What we can do in our own program, as we have been talking about, 14th November is coming up, maybe we can just do a lot of advocacy programs, newspaper articles, radio talk, keep talking. Often people say, why do you talk so much about type 1 diabetes? I don't see why not. Till the last person knows about it, we just have to go on and on. Even if 10 people do not appreciate it, it's fine. Involve NGOs. There are so many big NGOs who are looking for projects. You know, these are Rotarians, Lions, Giants, and they do all kinds of little things. So we can actually give them very profound projects. Just reach out to them. They want to do something for name and fame. We have mission at hand. Let's align and make them do it. I think that's a great way of doing it. Let them get the name and fame. At least our job will be getting done. Create T1D leaders. Celebrities can be roped in. GP awareness is a very important thing. So wherever you're talking about type 2 diabetes, I would request everyone to just add a last slide on type 1 diabetes. It would go a long way. I understand we cannot take talks on type 1 diabetes in every medical forum, but at least we can add a slide on that. At a national level, we definitely need a lot of school programs going to make a big difference. And as Sir said, Asha workers, Anganwadi workers, if they are aware, if this is part of a school health program, it would make a big difference. Now, as I said, we do not have quality care at a rural level, especially because our entire empowerment program, we think of a city where a doctor is accessible. That's why I started today from doctor empowerment rather than a patient empowerment. We just don't have enough in numbers. We do not have people who are updated to current guidelines. I get every day, every child I get is referred to me on a premix insulin with monitoring of blood sugar once in a week or once in a month as a type 2, and has been told not to eat rice, not to have potatoes, not to have fruits. And the child comes not only in bad diabetes control, but also in depression and doesn't want to live. Parents are depressed. Obviously, they would be. But why should a doctor not be updated? Again, that is our responsibility to update in these things. And unless we do that, we're not going to create total empowerment, because everyone has to speak the same language. We all have to be on the same page. Only then will this really make a difference. So locally, we can have lots of CMEs. We can talk to our local IAP bodies and create a consensus. We can keep updating through various newsletters. We can use farmer support to reach out to doctors. So these are things which we can do in our own community, in our own town. At a national level, RSSTI is making a big effort, but creating centers of excellence, creating training programs for doctors, create certified courses, and the presence and conference. As we can see today, it's a big step. Last 5 years, there's so much of presence of type 1 diabetes for doctors. Now, I would just like to go ahead here. Okay, we are talking about making insulin available for all and SNBG available for all, but it's also very important that we do not compromise with the physiological regime. One very interesting thing I have seen, that when they talk about empowering children with type 1 diabetes, it seems like giving free insulin. So just giving free insulin is definitely not empowerment. And if we just talk of insulin as a first step, then at least give the physiologically right insulin. So if you have to give, maybe cannot afford analogs, if you have to give regular insulin, at least not premix. It could be using regular and NPH. One could create a regime which is suitable for that child's age and growth, but definitely not premixed. So we have to be a little more firm, because if we give those options, those are the shortcuts that everyone would like to take, and we know that it is not good for our children. So how do we get this? Basal bolus is definitely expensive. Strips are expensive. CGMS pump is super expensive, but there are people who can afford it. There are people who get a refund, people who get sponsored by the government or get refunds. So let's identify these people and at least offer them. If we think they can't afford it, but sometimes it's very surprising. They will find a way if they know it is good for their child. So I feel no matter what background they come from, they should know about it. That is from our end. We should be willing for that. The inertia should not be at our end. We can support children with pharma involvement. So many pharma companies give insulin for the kid. Even if they give for 5 children, you can support 100 children that way. NGOs can do that. Organizations like RSSTI is already doing it. We can talk to local leaders. I have all these MLAs, MPs who have funds and they are willing to do this. They just need a bit of, muska. You have to just ask them, and they actually then end up doing it. At a government policy, we have to really fight. And I think we're all fighting. We need to have it in the school health program. We have to include it in the NCD clinics, a government registry or our own registry, because numbers is what's going to make it happen. And we have to have it as a fight for life, not of medical care, but it is a right to live, which is part of our constitution. So it's a long journey. I hope and I'm praying that soon we will not have to have these slides on our screen, because this is something we've been fighting for so long. Again, empowerment also comes from storage. Sir showed this pot and I'm so grateful for that. But today we have those cool bags. We can use those gel bags. We have so many things, but knowledge of storage from best of communities, I still find people not knowing. Again, it borders to education, but small innovations like these can lead to a good care. And once that good care happens, then the entire focus is on education. So this is where the most important part of empowerment comes, that how do we provide education with or without qualified educators? Even if we have a big team, a hospital, where we have 2 qualified educators, say, how many qualified educators would one hospital have? Even if I have a hospital with 2 and there are hundreds of children, how do you teach one-to-one? How do you do group program? What motivates them to come to you, right? How can you reach to them? So it's very, very important that we have individualized care as well as group care. And sometimes this hand holding has to be forever. There are people who cannot understand. So it's a huge challenge. There are no answers which are fixed or permanent or which fit everyone, but definitely we can look at the problem by training our paramedic staff through various certified courses. Today, ISPE runs a beautiful course already. In fact, in people who don't know it, they are doing it even for qualified people with type 1 diabetes. ISPE has launched its certified educator course in type 1 diabetes. RSSDI will be launching, has already started, and tomorrow I think it will be launched officially, and they can access this course to become a type 1 diabetes educator and even to become a coach. That is, people with type 1 diabetes or who are care providers for type 1 diabetes can become coaches in type 1 diabetes. So this is something now these courses are available. And if we hunt for them, our receptionist, our pharmacist, our lab technician, all these people can be trained, and that is a way we can create a team of educators, and we can create our own course as well. I mean, for the immediate needs, it would be easier as the DMOM program we said, but at a national level, we really need good educator programs. We need state programs which provide employment. Why would I do a course if there is no employment? So unless and until we hire educators and we pay them, why would somebody become an educator? Because ultimately livelihood is very important. So it's very important that we understand the importance of educators and hire them and pay them so that more and more people do become educators. And a good updated resource library like the one that is coming up with RSSDI would be something which will help in the structured education. So how we do this in Udan is, I'm just sharing it. There are children, we have game-based educations, youth, we have interactive learning, and parents, we have a topic-based teaching. So it's an age-appropriate teaching. And because they learn with their peers, it is also empowering because they've known. So lateral benefits are the mental, psychological, emotional togetherness. Ostensibly, they're just learning a subject, but since it is done in a fun way, it is done together, and we can divide the team on who does this education. So doctor does not directly have to spend time, which is a major reason that education does not happen. Now, Mighty Mom Sir shared, and this is a program that we founded, which was a D Mom becomes a D coach. So today I have 35 D moms who got trained in a structured education system because they had so much of empathy already and experiential learning. So we had to teach them how to teach. And that structured program led to a good education system. Again, we need very good toolkits. We have some amazing, as we just saw the whole app, we have interfaces, we have some very high-tech interfaces. Those we can definitely use. Some of the apps, even the Madhuraksha app is really good. Try it out. But we can also use simple indigenous games made from seeds. We can have handbooks in local languages. We can have WhatsApp group for disseminating messages and videos in local languages. Chote, small videos, these are things can go a long way. So teaching toolkits, people learn visually, or through hearing or through reading. So learners are of a different kind, and hence we have to teach in different ways. So it is our onus to teach differently. One very important thing I would like to add here for everyone, please do, if possible, start helplines, because 24/7 helplines is something that every person with type 1 diabetes needs. It's not only in unreachable areas, not in remote areas only. Even in a town in middle of the night, it can be an emotional crisis, it can be a mental crisis, it can be a financial, it could be anything, or a medical crisis. But just knowing that you can reach out to somebody itself is a huge, huge help. So we can create a team and start 24/7 helplines. A very important aspect of empowerment is how do you connect in between two visits. So children who come, families who come after a long time, like we saw in the pandemic, they lose motivation, they lose interest, they lose the entire energy, and sometimes the outcomes medically are also not so good. So the minus part is, of course, the long distances, sometimes low literacy, less finance. But the plus part is that we do have phones and internet. So that is one way we should really, in today's time, maintain communication with our type 1 families, it can be through 24/7 helplines or simple things like WhatsApp group. Of course, it can be wonderful interactive apps, but even at the simplest level, it can be just what takes a simple WhatsApp group. And most children, even the rural areas today, have a phone and internet access. Last but not least is that the spirit, which Sir was talking about, that once we have found and sourced insulin somehow, once we have found some way to monitor, then we have educated in all the basic things, found a way to connect. Still the spirit, the soul is somewhere, it needs a very fine nourishment. And that comes from various activities, as was seen in the previous talk. But one of the things which I can share, which we do, is various clubs. They like to trek. If you preach, nobody wants to learn. But if you do, it is learning. So when you're trekking and you're taking your 1 cup snacks, if you're checking after 2 hours, you're hydrating yourself, you're managing a hypo, and when you're dancing, when you are with your kind, you're doing marathons, theater, these are ways that you can empower them in a non-preachy way. If you have children, you know that not even with diabetes, other children and teenagers don't like to be preached to. They don't like to be told, do this. So the moment you start doing a structured lecture, they switch off in their mind. So this is a lateral way that we found that change the outcomes in our children. So what we really need to empower is not mere access of insulin and glucometers, yes, but today I would like to emphasize that is a base upon which we can build upon education, and we can build upon emotional, psychosocial empowerment as a team. So we need affordable, accessible, and acceptable care, which is individualized for children and their community. So this is a picture from 2007, which was our first trek. All these kids are now grown up, married. This is one of our first treks to Daulatabad, and these are an empowered community who are now contributing to the newcomers today. So our mission is ultimately to empower them, but let's empower our doctors, our educators, our availability of resources, and then we talk about education and psychosocial empowerment as well. Thank you so much.